Okay, pharmacodynamics. Pharmacokinetic is what the drug do to your body. What the body do to the drugs, the kinetics, what the drug do to the body is the dynamic. Now, this is a simple thing only, but I don't think it's important, right? Unimportant. How drugs function, mainly occupation theory and rate theory. So, these are sometimes like starter question. You think not important? Yeah, they will ask, man, receptor theories, so you say occupation theory, because there's a lot of implication later. See, occupation theory. The response of a cell to an agonist is a function occupation. I mean, you sit on it, there's a response. The agonist sit on the receptor, there's a response. And then there are two sub-theory, Clark and Stevenson. See, this one is our standard. The proportion of receptor occupied is proportional to effect. This is our standard. Our dose is one curve. The standard, more sit, more response. Correct? Then this one, spare receptors. This one says that maximum effect, only a small proportion occupied cukup. Only a small proportion occupied cukup. The rest, not necessarily spares. This one, the more you occupy, the more effect is the occupation. This one is very important because things like your muscle relaxants, especially your non-deporizers, if you need your muscle relaxants. Another example is the pufferfish. You know pufferfish? Pufferfish, the toxins, or these are actually is something very good to keep us alive. I think it's evolution, keep us alive. If you don't have this, can you imagine those who have like pufferfish? Now pufferfish, you don't die. You know the Sabah, the Sabah. I never tried before pufferfish. They say you eat pufferfish, you must eat just enough to get numbness. If you eat more, you will die. Because to kill you, you have to. That means our body, you know, the neuromuscular transmission, acetylcholine, come down, depolarize. So we don't need all the receptors to be depolarized before we can function, because I've got spares. Can you imagine if you don't have spares? Then you take pufferfish. Yeah, okay. You understand now? So that means we have a lot of spares, reserve. This is the Stevenson theory. Later you understand more. Rate. The response is a function of occupancy. The more rapidly potent, associate, dissociate, more rapid, potent. Slowly is not so potent. This will be detailed in local anesthetic toxicity. Local anesthetic toxicity. So you see like things like bupivacaine, sit onto the receptor, sodium channel, and never want to let go. So that means this one, mainly your muscle relaxants. Most of the drugs are narcotics, example. Some relevance in the local anesthetics. Now receptors. Binding sometimes people catch up, but nothing much. Oh, okay, this is very important. This is maybe an essay, a full essay. What are evidence of receptors? Evidence. See, you read. Evidence of receptors. They ask you, can you tell me some evidence that receptor exists? Son, this sensitive, specific, selective, saturable, subtypes, reversibility, ligand binding, endogenous, it's seen in the electron microscope, isomers. See this evidence of receptors. So if I don't tell you, it come out as full essay, you would not just bang, betul I told you it will come out. Oh, you play the fool. Actually, you don't have to know 10, or maybe you know 7, I think it should be okay already. Huh? Mechanism, ooh, look at that. Huh? This is evidence. Evidence can be assay also. Huh? Like mini viva lah. Oh, mechanism can be an assay. Mechanisms. See, receptors, the ligand-gated, G protein, tyrosine kinase. So normally the 1 and 2 very important. The voltage-gated, local. Inhibitors, membrane, colligative, structural, chemical, chelation, known. See, this one can be an assay. We assay, examples. So, let's just spend a little bit time on this only. Receptors. We are interested in receptors, and receptor function is occupancy and rate theory, and evidence of it, how it works. When you see this, are you scared? People very scared of G protein. But G protein is very easy. Actually, I know your fear, because we look so long, we ask question, you can see the eyes. Eyes can do two things. Either the pupil dilate, you can see, or they change color, become red. Then we know already, we know the eyes. Dilating, right? Dilating, no oxygen already. Wow, no. Tell me about G protein. Or they turn red. Turn red when they die. You instigate a bit more, they cry. So, ligand-gated. Ligand means something attached. See this dot is the ligand. The ligand sits on the receptor. Ligand sits on the receptor. Ligand sits on the receptor. Two things can happen. Stimulate this to open, or G protein. Ligand sits on the kinase. Ligands go into the nuclear cells. Okay lah. So this is a ligand-gated sodium channel. See, ligand sit onto the sodium channel, open. This one is indirect. You sit here first. So that, see, look at the color lah. This polka dot. This one very fast, very slow. Ligand-gated. Example, always this for us. All right. GABA or glycine, sodium, and MDA. So what does it mean? Which means, see, to stimulate is to depolarize. Stimulation means depolarize. Inhibit means stop it from depolarize. How to stop it? Hyperpolarize it. Okay, so when we talk about depolarize and hyperpolarize, we are talking about inside of the cell. Inside the cell. See GABA. GABA deal with chloride. Chloride. So chloride will, when open, chloride more outside. It will go in to the cell. Chloride is positive or negative. We make it hyperpolarized, more negative. More negative means far away from the threshold potential. So the flow go to sleep. Go to sleep. And GABA and glycine are chloride channels. So that means if we want to anesthetize you, I will make sure the GABA is strong. GABA agonist. Right? So GABA agonist will ensure the chloride go in there. Hyperpolarize, it cannot depolarize, so you go to sleep. Calcium and MDA. What does it do? Calcium is positive charge. When positive goes down, becomes the cell is getting nearer and nearer the threshold potential. So we stop it. As anesthetist, we want to be anti-NMDA. So that means all the drugs like NMDA antagonists. So we are pro this, anti this. You agree or not? Sodium channel. Sodium channel nicotine, local. So sodium channel. So when the sodium goes in, positive activate. So we block it. So that means for us, we want to sokong this, sokong glycine, anti this. You understand? That's how things are. That's the most fundamental. Sometimes these are the things that the Viva, and it's very fundamental. Can you imagine if you don't know this? But you can know everything in the world. I don't know this. Wow, okay. Yeah, you know, certain things are it's very fundamental. Very fundamental. G protein. G protein is actually very simple only. MCQ. 1, 2, 3, 4, 5, 6, 7. 7 loops. I don't know why. MCQ, they always love to ask. How many? There was 8 loops, 6 loops, 7 loops. 7 loops. 1, 2, 3, 4, 5, 6, 7. 7 kali. 7 kali. MCQ. N terminus is outside. E terminus inside. MCQ also this is nonsense, you know. And this is the G protein couple receptors. G protein link receptors. See, this is a G protein. This is important, you know why? Son got Nobel Prize, you know. The discoverer of G protein got Nobel Prize. And most of the drugs are actually acting on G protein. Now, affinity. This one, when you see these things, what will be the coming subsequently? Very rarely they just ask you for affinity. They won't ask. They'll mainly go to give examples of competitive, non-competitive, inhibition, agonists, antagonists, examples of agonists, antagonists, give examples, agonists, antagonists, and then competitive, non-competitive examples. So this one is just to remind you this is hyperbolic. Hyperbolic means we never lock it Now, affinity is how it binds to the receptor, the strength of it So everything we use 50%, easy to talk. So 50% is the marker of affinity, and 50% receptor occupied. So the affinity is a reciprocal. It means the more on this side, the more, that means this graph, the more it's shifted on this side, that means it's more, the affinity is higher. The more it shifts on this side, the whole graph. Now, this one, they may ask you to draw. What's the difference between what is potent? How do you describe? What is mean by potent? This drug is potent. This drug is potent. These are some of the questions there's a group of anesthetists when they ask why they're very fundamentalist. Good also fundamental. So what do you mean by potency? They'll say, what do you mean by potency? See, when you talk about potency, say you are powerful compared to somebody. When you talk about potency, you always compare with something. If you're alone, you're the most powerful person in the world. Correct? So when you talk about potency, you compare two things, or at least minimum. So they ask you to define what is potency, affinity, agonist, antagonist. When they ask you to do this, compare, define potency, define efficacy, define agonist, define antagonist. They ask you to define potency, efficacy, antagonist, partial agonist. They ask you to define in a Bible. How are you going to do it? Say the answer. Draw. Don't waste time. Don't waste time talking. You understand not? Because English is not your mother tongue. You understand not? In the exam, if you're lost for word English, you speak Bahasa, so I don't care. Speak Tamil, I don't know I speak Bahasa, actually I don't care. Campur also I don't care. You understand not? So you don't waste time, you draw. When this sort of question comes up, you draw. So you just draw percentage of resist or response, and then concentration, response, concentration, response. This is a log. When you see sigmoid, it is a log. When you see hyperbolic, it is not log. If it's sigmoid, it is log. So they ask you, what do you mean by efficacy? Then you straight line, you just draw A and C. Then you say efficacy is the maximum response possible. Then say, see, 100. You can draw 100. You can draw 100 even here, or this one. Say this one less. So this is more efficacious compared to A and B are more efficacious compared to C. Potency. When I talk about potency, we would prefer it to be the same shape. Alignment. That means same. So you say A is more potent than B. A is more potent than B because the KD is less in A than in B. Give up. So we want to compare potency between A and C is a bit difficult because they're different things. So you understand not? What I'm trying to bring this to you, when you see this, when he asks you to draw in the Viva, some student, because they like say English not a mother tongue, you try to fumble for words. Just draw. If I'm just draw see potency. All must be same shape. Sulfentane is very potent. The lower K, the higher the potency. Okay, now some fella will ask you, why do you like a sigmoid curve? This is a Viva question also. Why do you like a sigmoid curve? So you say, I like a sigmoid curve because sigmoid curve means log. Rectangular means not log. Rectangular hyperbola is not log. When you see this one, very difficult to compare. I want to compare drugs, very difficult. So you lock it. Once you lock it, all the same. See, can compare. Can compare. So normally it's between 20 and 80. 20, 80 is a straight line already. And we like to compare things, we like to compare straight line. Curving line, how to compare. So this is a standard question they always ask. Now, types of drug interaction, agonists and antagonists. Okay, don't waste time also. You say, they ask you to draw. See, okay. Now, agonists, therefore, see, full receptor affinity. Affinity, full. They love this thing and they got maximum response. Agonists, they love also. High affinity, very avid, but no activity. Partial agony, they love also, but half action only. Some partial action, inverse is opposite. So again, they ask you to compare contrast. Compare contrast. Don't talk so much. Just draw. Draw. See, then you draw. Okay, I say sigmoid. A and B are full agonists. You look. Maximum response. Full agonist. But B is less potent. C is a partial agonist. That's straightforward. I just tell you that the moral story here, draw, more, draw. Because if you want to explain, it's very wordy. We are not lawyers, right? Then they ask you what's the difference between full agonist and partial agonist. Just draw. Full, partial, draw. Remember, every time you got a sigmoid, it is log. It's wrong, right? Population, yeah. Okay. It's a response. It's a response. It's a response to be log. Hey, log those. Okay. Yeah, correct. I'm correct. Log those response. The log dose and response. Response can be 100 anyway. Now, same again. Log dose response. See? Partial, full. This also partial. Partial. See? Drug B is more potent than A. Potent because KD is less. That's right there. And drug C is less potent than drug A. Less efficacious. Draw. This is a killer. Not student to understand this. These are not students to understand this curve. Sometimes the examiner in Viva, they give this graph, put on the table, explain. Explain. So you see here, now a partial agonist. A partial agonist in the presence of a small dose of full agonist. A partial agonist in the presence of a small dose of full agonist is additive. Acts on power. A partial agonist in a full dose of a full agonist is an antagonist. The partial agonist can act as an antagonist also. Because you see, just like I told you, partial agonist acts as either agonist or antagonist. Alone it is an agonist. It's an agonist because it loves the receptor, but partial action. But when combined with full agonist, addictive effect, low dose of a full agonist is addictive. But when you switch, you can become an antagonist when the full dose of the agonist increase. Any application in this? Clinical application. Clinical application. What's the clinical application of this? If I tell you like that, you will never remember talking rubbish. Greek. But when I tell you the clinical implication, you will realize, which you all do, but you never realize. Clinical practice. What is the clinical implication of this? Any idea? Morphine with buprenorphine. See, that means buprenorphine is a partial agonist antagonist. So buprenorphine sometimes people use in, let's say, cancer pain. You got buprenorphine patch. Patch. Okay, okay, not that is a partial agonist. So when he go for surgery, you must give morphine, correct or not? So when you give partial little bit of morphine, the effect is additive. Where high dose of morphine, the buprenorphine will antagonize the morphine. You understand or not? You think about it and see. Which means those cancer patient, mainly we talk about buprenorphine. You understand or not? Let's say you got next case tomorrow, buprenorphine. It's on buprenorphine for cancer pain. Then you want to operate. So you give narcotic, not necessarily morphine, fentanyl, anything so can. When you get a little bit fentanyl, the effect is additive. When you give full dose also of your narcotic, the antagonist will block. Let's see. Partial agonist dose. Log dose partial agonist. See. It's quite correct. Starting with fixed concentration of full agonist. It's already fixed already to which partial agonist is added. See, A, B, C, D, E, R are starting by different fixed concentration in each of full agonist, of which partial agonist added. When you add, see, this increasing dose of your morphine or fentanyl. So as you increase the dose of your narcotic, see, small dose, it's additive. This load is going up. High dose of your narcotic coming down. That's how you explain. Low dose full agonist A. Low dose of this A is A, B, C, D, or full agonist. Low dose of a full agonist, just not A and H. Low dose of full agonist A, the partial agonist is addictive. That's why the slope goes up. This is response. See, response is increasing, right? Response is increasing. See, high dose full agonist, as you have increased dose of partial agonist, see, partial agonist actually is, see, the response is dropping. So the clinical application is buprenorphine, cancer application, and you give narcotic. Inverse, is opposite. The only one that we have known is ketanserin. Spare receptors, yes, this is a favorite topic also. The Stevenson, remember not? Was a Clark. Clark is a proportionate. The Stevenson. Spare receptors exist where a few will give the maximum response. The non-linear, because linear, the one is linear, your response is proportional to the occupancy. That's a linear. The remaining unoccupied, you can remove them without affecting the maximum response. They're spare. Because spare. The new muscle junction contains receptors which, when occupied by ACH, will depolarize. But then occupancy, only a small fraction of the receptors get the maximum response. The rest are spare. I think this evolution protect us. The spare parts. See, the spares, the protection against failure of transmission in presence of toxins or muscle relaxant. That means if you give very little bit, accidentally give very little bit muscle relaxant, we're still okay. We can still breathe. Correct or not? Hey, imagine we got no spares. Accidentally give little bit, occupy, then we die already. But there's little bit of muscle relaxant will actually block some of the receptors, but we got spares. We can still breathe. See, it's stated like that. See here. See, occupancy of receptor of muscle relaxant by more than 70% block. Only your T4 start to decrease. It's the train of fall. The fourth twitch is the last one. See, when you occupy more than 70, only T4 start to drop. When you block 10%, nothing happen. 20%, nothing happen. Only when you block 70%, only it start to drop. When you block more than 70, the fourth disappear. When you block more than 95, only the first one is see. That means actually we got a lot of spares. Protect us. If they ask you to draw a graph, what's the difference between spare receptors? It's the same as dose response. It's the same as the potency curve, See, this one no spares, you do like that. This is you will spare a lot of spares. Spare receptors. So what does a spare receptor do to your response curve? The more spare receptor you have, shift here. Shift to this side. Okay, shift to this side. Shift to this side.